Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the CRASH course are listed here. So let's start our case. In this case, we have a 15-year-old female brought to the clinic because she passed out while shopping at the mall today. She was sitting on a bench with her friends at that time. This was her third episode of passing out. The first time was 8 months ago while playing in her first volleyball tournament. She had not eaten breakfast that day and was discharged home from an ER after receiving IV fluids. The second episode was while arguing with her boyfriend 4 months ago. The patient denies nausea, vomiting or diarrhea, dizziness, palpitations, lethargy, persistent cough, chills, sweats, or weight loss. She denies any seizure-like activity during these episodes. She reports having trouble sleeping at night and feels tired and sleepy throughout the day. Her mother says she frequently falls asleep on the drive to school. Her grades at school have dropped in the past few months, and the teachers are complaining that she is inattentive. Past medical history, she had a normal birth, no hospitalizations. She does have mild asthma and uses albuterol as needed, especially during volleyball season. Her last menstrual period was 4 weeks ago. She has no known drug allergies and immunizations are up to date. She denies any high-risk situations or behaviors. Family history, the sister has asthma, her mother has migraines, and a brother and an aunt have epilepsy. And she has an uncle that died at 32 years of age suddenly with an unknown cause. Physical exam reveals an alert adolescent female in no apparent distress. Her vital signs: temperature is 36.2, heart rate of 84, respiratory rate of 16, and blood pressure of 100/60. Her height is 5 foot 7 inches. Her weight is 59 kilograms. Skin exam shows mild eczema and dry skin noted around the body. HENT is normal, except the conjunctiva are mildly pale. The throat has tonsils that are 3+, but no erythema. Neck is normal. Lungs are clear. Cardiac reveals a grade 1 to 2 out of 6 systolic ejection murmur at the left lower sternal border. Abdomen is soft and benign. GU is normal. Extremities are also normal. Neuro exam is non-focal. She is alert, has good motor tone, and deep tender reflexes are 2+ and symmetric, and the gait is normal as well. To summarize our problem list, we have a 15-year-old female who presents with syncopal episodes and sleep issues. She has worsening school performance, a history of asthma, family history reveals migraines and epilepsy, and a possible sudden death in an uncle. So in this case, we have a 15-year-old female coming in with a syncopal episode. So let's go through the differential diagnosis of a 15-year-old female coming in with syncope. The two big systems you have to think about are cardiac causes and neurologic causes. So anytime a patient comes in with syncope, those are the two categories, the two organ systems you should start off with first, is cardiac and neurologic. So let's talk about cardiac causes of syncope first. So let's create a differential diagnosis based on cardiac causes. And some of the more common causes related to the heart can cause syncope. And a couple big ones will include neurocardiogenic syncope, which basically is what we commonly refer to as a vasovagal type of response. So neurocardiogenic syncope would be a vasovagal type of response that we typically think about when somebody comes in with a syncopal episode. So that's high on the differential diagnosis. Other cardiac things that you can consider would be orthostatic hypotension. So orthostatic hypotension would be another cardiac cause that you would think about. And the third one that is similar to this is something called POTS syndrome, or POTS, postural orthostatic tachycardia syndrome. These three entities are some of the more common causes of cardiac causes of syncope. Neurocardiogenic syncope or vasovagal orthostatic hypotension, and POTS, also known as postural orthostatic tachycardia syndrome. I'm not going to go into the details of each one of these. You can look these up and read about them separately. There is some overlap with these three entities, and there's some subtle differences between these three as well. These are some of the more common causes when you have a syncopal episode that you have to consider. And again, you could read about the specifics about each one of these. But I want to move on to other cardiac causes of syncope, and another big one would be things that are causing an arrhythmia, so different type of arrhythmias causing syncope as well. Different arrhythmias can cause you to have syncope as well, and you can have either a bradyarrhythmia, right, so a slow heart rate, or some sort of heart block, right, or you can have a tachyarrhythmia where you have tachycardia, and then have a syncopal episode as a result of that. So bradyarrhythmia would be, again, some sort of heart block, a type 1 or type 2, type 3 type of heart block, causes you to have a slow heart rate, and then that can cause you to go syncopal. And then in adolescence, tachyarrhythmias, I think, are a big consideration. And other tachyarrhythmia, you can have things like SVT. Would be a consideration, right? So SVT, so whether it's paroxysmal SVT, or if you have something underlying like WPW, Wolff Parkinson White syndrome, that can predispose you to have SVT that can cause syncope as well. So those are a couple, something that you would think about under tachyarrhythmias related to SVT causes. And then you can have VTach, right? So ventricular tachycardia versus supraventricular tachycardia. So different causes of VTach that you have to consider as a potential cause as well. A couple of things to think about would be medications or other metabolic things that can cause you to have a VTach, or even illicit drugs. So VTach, you might think about drugs like cocaine or amphetamines and stimulant drugs. So that can cause you to have tachyarrhythmias and VTach and such. Or you can have issues with prolonged QT syndrome that can give you VTach as well. So QT syndrome issues, prolonged QT issues can do that as well. So you can have acquired prolonged QT related to metabolic things, electrolytes, medications, things like that. Or you can have congenital prolonged QT syndrome. And the two big ones that the board like to ask about related to congenital causes of prolonged QT syndrome, the two big ones are Romano-Ward syndrome and Jervell-Lange-Nielsen syndrome. And what the boards like to ask about for that is the difference between the two is related to hearing loss or having normal hearing. So Romano-Ward syndrome has normal hearing along with a congenital prolonged QT syndrome. Jervell-Lange-Nielsen has hearing loss in addition to the congenital prolonged QT syndrome. So the boards like to ask about that, so that's one way you want to differentiate that. But again, prolonged QT can be from again, acquired causes or congenital causes. So these may be some of the tachyarrhythmias that you have to worry about on a child that comes in with syncope. Other things that you have to think about cardiac causes, other things would be hypertrophic cardiomyopathy. So idiopathic hypertrophic subaortic stenosis or obstructive cardiomyopathy, that can cause you to have syncopal type of episodes as well. So that's something you always think about on an adolescent and athlete. We do have this family history in this patient of some sudden death. They're not sure if it was cardiac or what the cause of that sudden death was in a younger family member in their 30s. So that could be cardiac, that could be an obstructive cardiomyopathy, that could be related to prolonged QT syndrome. So there's some family history to suggest that there might be something cardiac going on as well. So obstructive cardiomyopathy can cause that as well. Other different obstructive type of processes would include aortic stenosis. So if you have a valvular issue, now you have aortic stenosis, and that's causing you to have obstructive outflow issues and causing you to have a syncopal episode. And then if the patient had some sort of viral process, another thing that you can think about is kind of myocarditis or pericarditis as well. So if they had a recent viral illness, you might think about myocarditis, pericarditis, cause you to have cardiac dysfunction, and that can then lead to the syncopal episode then. So I think these are some of the things you have to think about, cardiac causes of syncope in this patient. And again, cardiac is one of the earlier things you have to think about immediately when a child comes in with a syncopal episode. Make sure it's not cardiac. Then the second area that you're going to always consider is going to be neurologic causes. So we can move on to neural causes of syncope. So a big one in this category would be seizures. Right, seizures can present with syncopal episodes. So you could be postictal and have a seizure that nobody witnessed, and then you are postictal and you pass out. Or there's a specific type of seizure called atonic seizure, where you just basically kind of drop and don't have any atonic clonic type of activity, but you just kind of have an atonic type of episode. These are called drop attacks. Is another word that some people will allude to with these atonic type of seizures, or these drop attacks. So that's something that a child with syncopal episode without any obvious seizure activity, tonic clonic activity, could be presenting with this type of a seizure. Other things that can cause syncope, migraines can also cause you to have syncopal episodes. So that's always on the differential from a neurologic perspective. Any type of trauma, intracranial hemorrhage, bleed, anything like that, an AVM rupture, an undiagnosed AVM that's not ruptured, so anything that causes trauma or bleed intracranially can cause you to have a syncopal type of episode as well then. And then other neural things, you could think about tumor, so different types of malignancies that can present with a bleed or increased intracranial pressure, causing you to have the syncopal type of episode, so that's something to consider as well. Another neural thing, depending on the presentation, would be infection, right? Any type of meningeal encephalitis type of picture, so a CNS infection causing you to have a syncopal type of episode, or be kind of encephalopathic. That's on the differential as well. And then another one that we can put under neural would be narcolepsy. Sometimes sleep disorders and sleep disturbances can present with these type of syncopal episodes as well. So I think, again, when you have a patient presenting with a syncopal episode, the two big organ systems you have to think about are cardiac and neural, and these are some of the things that you would consider on the differential, especially from a cardiac and a neurologic perspective, highest on the differential then. And then after considering cardiac and neural, then there's other things that you would have to think about on the differential diagnosis. So the other things you would start to consider on the differential diagnosis, especially in an adolescent patient, would be some sort of ingestion or drug abuse, right? So we can put that up here. So drug abuse, so different ingestions / ingestion. So that's a consideration in adolescents. So again, we talked about, we mentioned over here like cocaine, amphetamines, and lots of other sedatives and different medications that can be used. So anything, any type of meds or even illicit drug use can cause you to have syncopal episodes. So drug abuse, ingestion, meds, illicit drugs can do that as well. Other things that you have to think about, common things being common, right? In a 15-year-old female, right, you got to think about pregnancy. So make sure that you do a pregnancy test on this type of a patient coming in with syncope. Other things, other categories we can think about are metabolic causes. So when you think about metabolic, I'm thinking more type of kind of electrolyte type of issues, right? So sugar issues, right? So you can have a high sugar or a low sugar, right? So a patient in DKA with a high sugar can be syncopal and encephalopathic, dehydrated and things. Low glucose, right? If you skip breakfast or you haven't eaten for a while and you get hypoglycemic, that can cause you to have a syncopal episode as well. So a high sugar or a low sugar can cause you to have that type of imbalance. And then other electrolyte things that we talked about could be related to cardiac arrhythmias and prolonged QT. Could include electrolyte issues, so you can have sodium issues, or calcium issues, or even potassium issues, right? So depending on what's happening with the patient, if they have some sort of electrolyte imbalance, an eating disorder, vomiting, dehydration, diarrhea, could throw off your electrolytes, and that can cause you to have syncopal episodes or cardiac arrhythmias that can predispose you to the syncope. And then when you think about metabolic, always think about endocrine issues. So in addition to metabolic slash endocrine, we kind of alluded to, actually we didn't allude to it here in cardiac, but tachycardia. One of the things to consider is hyperthyroidism. So when you have a hyperthyroid type of issue, that can cause you to have syncopal episode, hyperthyroidism. So again, that can lead to especially tachyarrhythmias and SVT or VTAC and things as well. So endocrine issues. So if you have hyperthyroid, right? So if you have hyperthyroidism, that can cause you to have a syncopal episode related to cardiac arrhythmias. Then also again related to metabolic and sodium or potassium, anything that gives you adrenal insufficiency. So whether you have like Addison's disease, or if you have congenital adrenal hyperplasia and kind of a milder form of that, it's CAH. So anything that gives you adrenal insufficiency can again cause you to be dehydrated, cause you to have electrolyte imbalances, cause you to be hypoglycemic. So it can cause you a lot of different issues, and that can present with syncope as well. So adrenal insufficiency under endocrine as well then. And then again, 15-year-old female, you think about pregnancy, but also because of the fact that they're menstruating, she can be severely anemic and can have a syncopal episode related to that. So under heme, you can think about anemia. So if she has heavy periods and lots of bleeding, and gets severely anemic, that patient can present with syncopal type of episode as well. And then another category could be pulmonary related. So when we think about the pulmonary system, if you have enlarged tonsils, enlarged adenoids, and you're obese, you can have obstructive sleep apnea, and that can cause you to have pulmonary hypertension. And that can cause you to have a syncopal episode as well. So obstructive sleep apnea and pulmonary hypertension, I think, are consideration for syncopal episodes. Now, our patient is having some sleep issues, doesn't sleep well at night, falls asleep in the daytime. That could be related to obstructive sleep apnea and pulmonary hypertension, and issues related to that then. So that's definitely a consideration on our patient as well. And then again, 15-year-old adolescent female, you have to think about collagen vascular, autoimmune type of stuff, so things like lupus, different type of vasculitis type of process, can present with syncope and things related to hematologic issues or neurologic issues related to collagen vascular disease. So that's always a consideration on a 15-year-old female coming in with syncope, different autoimmune issues, and collagen vascular disease. And then I think another area or category to think about is going to be psych issues. So she's a 15-year-old female coming in with syncope. So another category is always going to be psych issues. So as I mentioned, eating disorder related to electrolyte type of issues. So the eating disorder is a consideration in this type of patient. And then other things like anxiety or depression that can affect your sleep, that can affect your overall health. Anxiety can cause you to have tachycardia, can cause you to have hyperventilation. So all that can lead to syncopal episodes as well then. And then other like sleep issues we kind of alluded to already, but sleep disorders either related to an underlying primary psych issue, or other things like the narcolepsy, or just poor sleep hygiene, right? 15-year-old adolescent patients don't sleep much at night, or they go to sleep really late and then they have to get up early to go to school, so they have sleep deprivation. and then they're falling asleep at school and they're not as alert and things. So that can cause it as well, and they finally just get so fatigued and things that they can have a syncopal type of episode as well. So I think these are some of the things to consider on our patient here. The differential diagnosis of a 15-year-old girl coming in with syncope. Again, the big things are always going to be cardiac causes and neurologic causes. Those are the top two things, organ systems you're going to think about on a patient coming with syncope. And then you think about other causes categories as well: metabolic, endocrine, heme, pulmonary, psych, and then like cardiovascular and other ingestions and pregnancy on the 15-year-old female that you would think about as well. So I think in our patient, given all the history and her own history and the family history, again, cardiac, you always got to think about that. It could be something simple like vasovagal or neurocardiogenic syncope in a 15-year-old girl, or she can have some sort of arrhythmia or obstructive cardiomyopathy, so something cardiac related to meds or drugs. You got to think about that. And then there's a history, family history of seizures. So think about seizures as a cause, like the atonic seizures or the drop attacks. And then other things to consider neurologically. Make sure she's not pregnant, make sure she's not hypoglycemic, make sure there's no drug ingestion or medication ingestion, make sure she's not anemic. So I think these are a lot of the things you would consider on this patient that presented with syncope. So again, that's the broad differential diagnosis. Now let's look at how the case unfolds in our 15-year-old patient presenting with syncope. So in the ER, our patient had a pretty extensive workup to rule out cardiac causes and neurologic causes and some of the other common things that we're thinking about. So she had a CBC, which was normal, did not show any anemia. She had a complete metabolic panel, and her electrolytes were normal, her glucose was normal, kidney function, liver function, everything was totally normal. She had a urine drug screen, and that was negative for any type of illicit drugs and other type of ingestions. She had a pregnancy test, urine pregnancy test, and that was negative as well. She had thyroid studies, a free T4 and a TSH level, and those were all normal as well to help us rule out the thyroid issues. She had a cardiac workup, she had EKG, she had echo, and those were both normal as well. And then she had a CT of the head in the ER setting, and that was negative as well. No bleeds or no hydrocephalus or anything obvious that was seen on a CT. And then she also had an EEG that was negative for any type of seizure activity as well. So she had a pretty extensive neural workup and cardiac workup, and then other type of workup that all basically came back normal at that point. And she was discharged home to follow up with her primary care doctor. When she started primary care doctor, as he kind of reviewed the history, there seemed to be some issues with sleep, where she had trouble sleeping and she'd fall asleep in the car on the ride to school, fall asleep at school. So there was some concern maybe she had obstructive sleep apnea, or she had some sort of sleep disorder, or even like narcolepsy, something like that. So she ended up having a sleep study and was sent over for a full sleep study. And the sleep study did demonstrate that she actually had a diagnosis of narcolepsy, and the type of narcolepsy she had was the cataplexy, where she would just suddenly drop and lose muscle tone as part of her cataplexy portion of her narcolepsy. So that was a diagnosis that she was ultimately given based on the sleep study. So narcolepsy is not that common, but it is something to think about in school-age kids and young adults and adolescents. And she had some of the findings where she would just suddenly, kind of drop and kind of fall asleep, or she'd be sleeping in the car ride to school, or sleeping, in the school during school itself. So she had some of those type of findings. Now, cataplexy, which is the type of narcolepsy she had, you can have a sudden loss of muscle tone tone related to strong emotion. So when you're like really excited, or you're angry, or you're laughing, you can have this sudden kind of drop attack and have an episode. And her episodes, looking back in history, were kind of related to that. The one episode was when she was in a volleyball tournament, so she was probably super excited or anxious. And the other one was when she had a fight with her boyfriend, so again, some strong emotions there. This one, she was just kind of at the mall, so I'm not sure what was happening at that time, but maybe something precipitated it at that moment as well then. So this patient, as with most patients with narcolepsy, are treated with a stimulant type of medication, so like the methylphenidate or some amphetamine, type of product. So stimulants are usually the treatment initially to help these type of patients. But one thing also to consider is a patient is falling asleep at school. You think about, again, the obstructive sleep apnea, but you also think about like anxiety and depression and maybe ADHD or a learning disability or absence seizures. So when a child is not performing well in school, or is not really paying attention in school, or is having difficulty focusing, or is sleeping in school, those are some of the things that you have to think about as well, in addition to a sleep disorder that might be causing that as well. So ultimately, our patient was started on stimulants, and her symptoms improved. So this case, I think, really goes over the differential diagnosis of syncope. So again, I'm not going to go into a big discussion about narcolepsy or each one of these entities. The idea, again, of the CRASH cases is to think of a broad differential diagnosis and kind of reason through the patient and analyze what's going on. So this is the differential of syncope, and again, you can go back and read more specifically on some of these individual entities, but hopefully this gives you an understanding of how to approach a syncopal patient, and the neurologic causes and cardiac causes and some of the other things that you have to consider as well. So hopefully this CRASH case was educational and beneficial, and we hope to see you at future CRASH cases as well.